Good afternoon. I'll talk about elbow overuse injuries. I like to start this talk with the definition of overuse. Overuse is basically an excessive and repeated use that results in injury to anatomic structures, whether due to sports or work repetitive tasks. This is a fly from a campaign from STOP, and STOP stands for Sports, Trauma, and Overuse Prevention, remembering that nearly half of all injuries sustained in middle school and high school students during sports are in fact overuse injuries, which is a lot. And in fact, most overuse injuries can be prevented with proper training and common sense. And remember that no pain, no gain does not often apply. So basically, a quick introduction. We have primary and secondary static stabilizers in the elbows shown here. Primary statics are the entry band of the UCL, the lateral and the radial collateral ligament, as well the coronoid process. And the secondary static stabilizers are the common extensor, common flexopronator mass, as well as the radial head. And then we have the muscles, which are the dynamic constraints of the elbow. So, whenever we have a chronic stress, whether by sports, overuse, or work repetitive tasks, the elbow stabilizers may end up to fail, and this may result in an elbow overuse injury. This is a short outline of this. For this talk, I'll talk about some overuse injuries of the tendons, as well as other related overuse injuries that are more common in the stable elbow, as shown here on this list. We'll start with the epicondylitis that we all know that is due to chronic overload leading to mucodegeneration, neovascularization, that finally may end up in tears of the common flexor or common extensor tendons. With this in mind, we can actually realize that epicondylitis is a misnomer, since the underlying pathology is related to chronic degeneration, partial tendon tearing, rather than an acute inflammatory process. However, it's still a popular term, and I will use epicondylitis during this talk. So I'll start with lateral epicondylitis. This is the most common elbow pathology, affects the common extensor tendon and the extensor spinator mass, usually affects the dominant arm, and is commonly associated with two situations. One, overhead sports, usually like squash, racquetball, tennis, and here's the moniker tennis elbow. Do notice that usually affects players with a single-handed backhand and not with a double-handed backhand. And secondly, also occupational activities, including, for instance, plumbing, meat cutting, racking, may also lead to lateral epicondylitis. Recognizing pathology implies knowing the anatomy. The common extensor tendon is composed of the extensor carpi radialis brevis, extensor digitory communis, extensor digitory minimus, and the extensor carpi ulnaris, all originating at the lateral epicondyle, very close to the radial collateral ligament lateral origin. Extensor carpi radialis brevis is the most anterior and deep component of the common extensor tendon, as shown here, and is almost always involved in lateral epicondylitis, followed by the anterior edge of the extensor digitory communis. We should check for the lateral and the radial collateral ligament because they are often involved, and both ligaments have a proximal conjoint origin right next to the extensor tendon. Another tip is to use all three MRI planes to evaluate the lesion. I mean, the coronals are pretty images and allow us to see the ligaments better, but the axials and the sagittals will be able to determine the extension of the tendon involvement. Occasionally, we can have secondary signs associated with lateral epicondylitis, like, for instance, some settled bone marrow edema on the lateral epicondyle, an increased signal on the conus muscle, or very uncommonly, radial nerve entrapment. We should characterize the tendon as normal, tendinopathic, or torn, whether it's partial full thickness as shown here on these cases. Remember that the normal signal intensity within the common extensive origin may be seen in asymptomatic patients. And also remember that the normal signal intensity may be seen in and around the common extensor tendon for up to 1 month following steroid injections. Again, you should always inspect the lateral and the radiocollateral ligament. Again, they are often involved in the lateral epicondylitis, and imaging findings must always be correlated with the clinical presentation. Moving to the other side, we have medial epicondylitis in this setting due to overuse of the flexor pronator group at their origin, usually seen in sport, mainly athletes, and also occupation activities associated with repetitive valgus and flexion force. Although it's commonly referred as golfer elbows, tennis has been the sport more commonly implicated, including professional tennis players with proper technique, as well as other type of players like baseball pitchers, racquetball, and golfers too. Common flexor tendon attaches to the medial epicondyle, and this is the conjoint tendon of the flexopronator mass, meaning pronator teres, flexor carpi radialis, palmaris longus, flexor teres officialis, and flexor carpi ulnaris. So on the medial epicondylitis enterocomponents, that is the pronator teres and the flexor carpi radialis, are most commonly involved. And again, to proximity, we need always to check anterior band of the UCL and ulnar nerve. They may also be involved. And again, you should use all 3 MRI planes, not only coronals, but also the axials and the sagittals to assess these structures. We should characterize the tendon as normal, tendinopathic, or torn. Again, a couple of examples from tendinopathy to tears. And don't forget, the imaging findings must always be correlated with the clinical presentation, just like for lateral epicondylitis. Ulnar neuritis, often seen with medial epicondylitis, well, that's why I'll mention. So, the nerve goes through the cubital tunnel, shown here in the scheme, bounded by the posterior band of the UCL, which is the pavement of the tunnel, and the roof, which is the arcuate ligament or the ligament of Osborn. And the cubital tunnel is the most frequent compression site of this nerve at the elbow and proximal forearm. On MRI, what do we see? We can have ulnar nerve edema, meaning high T2 signal on fluid-sensitive sequence. You can also have increase in the area of the nerve. Also, you should look for indirect innervation signs like muscle edema or muscle atrophy. And regarding the causes of entrapment, we can have a static compression, like for instance a mass, or importantly in the setting and the dynamic compression often associated with overuse injuries. And how does this happen? This happens because, as we all know, the ulnar nerve changes its size with elbow flexion and extension. With extension, the ulnar nerve is relaxed within the tunnel, as shown here. However, with flexion, the posterior band of the UCL bulges medially and the ligament of Osborn will become taut and straight, so the ulnar nerve is actually squeezed inside the tunnel. So with continued and persistent flexion, as occurs in throwers and other sports, players tend to have a dynamic overuse ulnar neuritis that usually comes along with medial epicondylitis. Another cause of symptoms is the synovial fold syndrome or radial humeral plica syndrome. Plicas are folds of synovial tissue, remnants of embryonic septa. This is a beautiful paper from Luis Rizal published a couple of years ago. It shows nicely the radial humeral plica located at the proximal edge of the antral ligament that is surrounding the periphery of the radial dome. Has several components depending where we are at. I mean, you can have the antral fold, the lateral fold, the posterolateral fold, or the lateral cranial fold, or not commonly, you can have a complete circumferential plica too, up to 50%. Trauma or overuse can turn these plicas into symptomatic structures and can be compressed between the radial and humeral heads during movement, and dysfunction is a consequence of direct or repetitive microtrauma, whether due to sports or manual worker. Why is this syndrome important? Because it can mimic lateral epicondylitis clinical. Regarding imaging, when do these plicas become symptomatic? The answer is actually we don't know so far. There's no agreement regarding size and shape. Papers show different results. The cutoff of 3 to 4 millimeters of thickness has been suggested by some authors. Others suggest that these plicas need to cover at least 30% of the radial head, but in fact, there's no agreement, no definitive threshold for size so far, so size might not really matter that much. So besides size, my usual advice, look for secondary signs. These might be helpful, like for instance, the chondral frame of the radial head or the capitellum, and for posterolateral synovitis. Moving on to the distal biceps. Distal biceps injury is much less common than the proximal the biceps injury, and they are commonly seen mainly in sports associated with weight training. Distal biceps inserts at the radial tuberosity commonly consists of two independent units. The distal tendon coming down from the long head, as shown here, red, inserts more proximally in the radial tuberosity as shown here, and the distal tendon of the short head, as shown here in blue, inserts on the distal part of the radial tuberosity as shown here. So we have the distal tendon of the long head more proximally, and the distal tendon of the short hair that inserts more distally. And then we have another important structure. This structure is over here. This is the lacertus aponeurosis that arises at the level of distal biceps myotendinous junction. This is the myotendinous junction here on axial T1 plane. And there is the lacertus along with the distal biceps tendon and its two units coming down till its insertion onto the porosity. Don't forget the distal biceps tendon does not have a tendon sheath, so please don't call it the tenosynovitis. Instead, there is a bursa named the bicipiteradial bursa. There is normal collapse and not visualized under normal conditions. So don't forget the distal biceps tendon goes down. Axial should cover at least 5 to 7 centimeters distal to the joint line. We should use both axials as sagittals to evaluate the distal biceps, and often if we can have time, we can do a FABS additional sequence, as shown here in this paper published some years ago, with the patient under flexion, abduction, and supination. That will be very helpful to grade distal biceps injuries. Distal biceps being normal, tendinopathic, or partial, completely torn. tears usually occurs up to 1 to 2 centimeters proximal to the radial tuberosity. Regarding partial tears, it's important to tell if less or more than 50% of thickness because it has different treatment approaches. And here again, FAB's sequence can be really helpful. So shown here, this is a low-grade partial tear, less than 50%. This is a high-grade partial tear, more than 50%. This will probably have a surgical approach. Full thickness tears of the distal biceps they happen near or at the insertion of the tuberosity. Your surgeon will ask you to quantify the tendon retraction, which can be done easily using the Sagittals or the FABS sequence. And you should tell him if the aponeurosis lacertus is intact or not. If intact, there will be little retraction, so the clinical evaluation will be more difficult. Notice that a good rule of thumb is that with less than 8 centimeters of retraction, typically there's an intact lacertus. However, if more than 8 centimeters of retraction, there is usually a torn lacertus. Finally, the triceps is the major extensor of the elbow. Distally, the long head and the lateral heads will merge, as seen here, into a common superficial tendon that will insert on the olecranium. And the medial head, as shown here, has a separate insertion, a muscle insertion that is located deep to the superficial tendon, as shown here. So we have a superficial tendon, and a deep muscular insertion. Usually, tears occurs at the insertion of the olecranium. Full thickness tears are usually more common than the partial tears. Whenever we have a tears, we should tell the surgeon which components are involved. This is the most common pattern. The deep muscular insertion is intact and the superficial tendon is torn and retracted, as shown here. But you can also have a partial deep where the muscular insertion is stored and the tendinous insertion is intact, or you can have a complete tear where both insertions are gone. We should also try to quantify the tendon retraction. This is because reattachment can be attempted if retraction does not exceed grossly 5 centimeters, and tell the surgeon if you see abnormalities like, for instance, bone avulsion. Finally, my top 3 bone differentials in the elbow. Osteochondritis dissecans of the capitellum usually occurs in children 12 to 15-year-olds. This is usually a focal lesion, usually at the anterolateral capitellum, that may progress and result in blue spots. This is very different from the Penner disease. This is usually found in younger kids, usually 7 to 12-year-old, often in baseball pitchers, and involves the full capitellum, so it's not focal. There is usually diffuse bone edema. This is a benign, self-limiting entity, so there's no loose bodies. Just a quick word for the pseudo-defect of the capitellum. This is a potential pitfall that may simulate an osteochondral lesion, but it's not, so please don't call it an osteochondral lesion. That's wrong. Finally, some take-home points. We can have injuries of the anterior and posterior elbow. We mentioned the biceps injuries and the triceps injury. On the lateral side of the elbow, we can have lateral epicondylitis, evolved the common extensor tendon, and mainly the extensor carporadialis brevis. You also mentioned the plica syndrome that may mimic lateral epicondylitis. And on the medial side, we can have medial epicondylitis that may be associated with ulnar neuritis that we talked about. Thank you. This is the end of my talk.